a consultant radiologist of CT and MRI sections at PD Hinduja Hospital, Mumbai. She's won awards for scientific exhibits at the 2011 RSNA, 1995 RSNA, as well as the 20th International Congress of Radiology in 1998 at New Delhi. Our second chairperson is dear colleague and radiologist Dr. Asif Momin. He's the head of imaging at the Head and Neck Cancer Institute of India and Bhatia Hospital, Mumbai. He has a silver award in KCR 2013 on radiofrequency ablation of liver lesions using contrast and fusion imaging, a gold award in scientific programs at ACTA 2016, KSUM 2018, Ultrasound Educator Award 2020, gold award at KSUM 2023 for paper on recurrent varicose veins, and he is the organizing chairman and faculty of multiple national and international conferences. And finally, Dr. Vani Parmar, she is a surgical oncologist specializing in breast. She's one of the most respected breast surgeons who superannuated from Tata recently, and TMH's loss was the gain of Punyashloka Ahilya Devi Holkar, Head and Neck Cancer Institute of India, Mumbai.
Dr. Shalaka. She will be speaking on planning breast conservative surgeries, the midnight calls. My God, really. I think this is something that you must have started to have a midnight call regarding breast conservation. So please, let's hear it out.
Thank you, madam, for the kind introduction, and thank you, Palak, and all the organizers. I'm just having a hearty time to see that after a handful serving of moong dal halwa, still so many people are here to listen to clinicians about their take on breast radiology. So my conclusion, my take home is already that radiologists are the most sincere academicians, because there's so many of you here, and I now have a face for every name that I read on the report. So midnight calls, let me explain, was a term that Palak and I, when we were only free at midnight, after our respective kids had gone to sleep and after we were back from TMH, and this was day before surgery. So I finally need to know what I'm going to operate upon. So I finally need to talk to the radiologist if I haven't done that earlier because of being busy. So I would always message her at 11:30 past, around that ungodly hour, and say that, tell me where is the tumor, or how is it, or tell me the extent. And we would have the discussions at that time, and it would be nothing less than 30 to 45 minutes if you have already realized how much Palak and I talk individually otherwise also. So that is why the topic is midnight calls, but it's essentially about breast cancer and planning surgery. I don't think I need to really tell you that it's a common cancer now in India also. It's an elephant in the room that you can't ignore. The incidence is 30 per 100,000 patients, and 1 in 29 women is the cumulative risk, which is quite a high risk. At Tata Memorial, this is an old slide of Dr. Neeta's, and we had 20,000 patients seen over 5 years period. 65% were fortunately operable or early stage T1, T2, N0, N1, and 35% were locally advanced, and we cater to these many number of patients. So if you look at the breast conservation surgery rate across the country, this was a paper written by Dowell sir from Delhi not very long back, and this is actually looking at metro cities, Chennai, Bangalore, Delhi, etc., minus Mumbai, and the incidence of breast conservation is 21%. So even at this stage, we are offering breast conservation only to 20% patients diagnosed with breast cancer. And TMH, we have a philosophy led by Dr. Badwe and Dr. Vani Parmar, from whom we learnt everything, that we do a breast conservation surgery whenever it is feasible. So our rate in this 2008 data was 63.9%. As of today, we offer breast conservation to 70% of patients with early breast cancer and to almost 50% of those who also present with locally advanced breast cancer. So this evolution of breast conservation in Tata was obviously led by surgeons to begin with, but the ladder of imaging evaluation of breast has really, I have seen, I'm at that age now that I can say that over last decade I have seen this progress to this level. So I'm talking about an era where we just had a mammography, and maybe one of our clinicians said that you can operate based on your clinical examination, you don't need to look at the mammo also. But yes, we do a mammography for every breast conservation surgery, so that's the bottom line, all patients get a mammo. last 5 years, I have seen with great effort from the head of departments and Palak and all the radiologists, Aparna, Purvi, that we have an armamentarium of breast imaging to offer to our surgeons and to our patients to plan surgery better, like an ultrasound, which was always there, but contrast enhanced mammo, digital breast tomography, MRI, and MRI with a breast coil, of course, and all the vacuum assisted biopsy procedures, which you've heard so much about in the last 2 days, which we did not have earlier. So it was told to me 5 years ago that if you don't have a vacuum MRI guided needle, don't do an MRI. So it was to that extent. So now we have an MRI compatible needle. We can do the biopsies or VAPs, so we can do MRI if required. Of course, for the case, that's why it's at the top of the ladder. It's a small font size to say that those many fewer patients really require an MRI. So for breast imaging, its use for a surgeon is in the diagnostic setting, in the screening setting. I'm not going to focus on that. Interventions, which my friend Saujanya is going to talk about later, and follow-up, of course. I'm going to focus on surgical planning. Just one quick example of diagnostic setting. And how the clean rad path correlation helps, which we have already heard through various panels over the last 2 days. This 37-year-old who comes with a left breast lump has a palpable lump of 1.5 centimeter at far 9 o'clock in the left breast. An ultrasound gets done, she's young, which shows something which is suspicious, something which is elastography showing something hard. And my disclaimer is that my images are taken by my own self, sometimes from packs as per my understanding, so just pardon me if they are not up to the mark. And other than that, there is something again suspicious, which is 4A, which is at 11 o'clock, 12 o'clock. That's a mammo. I think this far 9 o'clock was the actual lesion that she presented with, and the mammo was otherwise quite innocuous. But when we had the ultrasound suggesting that there was some cyst and there were some more lesions which were away from this, we resorted to doing and of course we had done a left breast core biopsy, which was a palpable lump. However, it was small, so it was ultrasound guided core biopsy, and that showed complex papilloma with ADH. And then we did an MRI because the patient was also quite keen on conservation and wanting to understand what's happening in the rest of the breast. Are they cyst or is there something more suspicious? So we did an MRI which showed the same lesion at far 9 o'clock in the left breast and something at 11 to 12 o'clock again in the left breast. This was palpable to us, the left 9 o'clock lesion. However, the 11 and 12 o'clock got sonolocalized. This is how we localize lesions on ultrasound, and we put an asterisk for the index lesion, a cross for a suspicious lesion, and a dot for a benign lesion. That's some terminology that we have developed so that we can interact. When I look at it, I know what the radiologist is trying to tell me. So we operated and took out the 9 o'clock lesion, which was also palpable, and the 11 o'clock lesion. And the pathologist did beautiful pink and blue staining on that. The 9 o'clock one was a complex papilloma with UDH, and the patient was benign, and we sent her home. So there is this clean rad path correlation that happens in our DMG, in our MDT, for every case. Some cases do not require much discussion, so they get passed off easily. Some cases require much discussion and planning as to what is to be done. So for surgical planning, there is no alternative to thorough clinical examination. What the surgeon can examine and palpate is quite important because that's what you're going to operate on. And imaging assessment is mandatory. So what we really need to know from the radiologist is delineation of the exact extent of disease on imaging. Is it what I'm palpating or is it something more than that? That's number one. Then I'm going to plan the extent of resection based on how much the clinical examination shows and how much the mammographic evaluation shows, and decide whether the patient is going to require some plastic surgical procedure or not. To determine the significance of additional lesions, like if there are satellite nodules, second tumors, or some cysts seen, are they complex, or can they be ignored? We need to understand that. And sometimes when you have more than one lesions, to understand whether they're multifocal or multicentric, what is the distance between the two? Is this patient a candidate for mastectomy, or is she okay for a breast conservation surgery? Is it oncologically safe? All this discussion happening preoperatively avoids an on-table surprise and a sudden conversion to mastectomy or a sudden requirement of an oncoplasty, which should be actually pre-planned very well the day before, hence the midnight. At least the midnight before the surgery, you need to know what you are definitely going to do tomorrow. But yes, you could discuss this 1 week before, but believe me, I forget often. Just I guess age is catching up, so I forget if I have discussed earlier. So I again ask the same question to my radiologist the night before, and hence that's the topic and the name of it. So just give you some examples of some cases now where how we cross-talk with our radiologist and pathologist. You don't often need them. Once they have given a report for this case, the lady who's come with a palpable lump, And this is the mammo. It's quite clear. I don't need to call Purvi, Palak or Aparna and hound them anymore. I know I'm going to do a straightforward breast conservation surgery. And they are going to do the pathology IHC4 and then we are going to decide further. So often cases are like that much discussion is not warranted. This is a case where another area which we use imaging often is response assessment post-chemotherapy. So if you have a tumor like this, 4-5 centimeter palpable, large tumor, high-grade young patient, you would give some chemotherapy and you would look at clinical response, of course, and then you look at a mammographic response. Again, when you see a mammo like this and an ultrasound may be combining with this, I'm not getting into debates of whether MRI should be done for post-chemo response assessment. We do not do that routinely as of now, but we do it for a few certain select patients when we think it's necessary. So a little more complicated cases now. This is a 50-year-old lady who had a left breast lump, palpable 4 to 5 centimeter, and if you can notice a mild nipple retraction at this point in the upper central quadrant. And that's all she came with. Everything else, opposite breast, axilla, everything else was normal. That is the mammography first evaluation that we did. Left breast, the same palpable area has an abnormality, which is however you describe it mammographically, it's BI-RADS 5, so its biopsy is needed. And contralateral breast showed this. So when and it was also there on the MLO view. We did an ultrasound. Ultrasound also showed a contralateral breast lesion in the right side. So the report said left breast lesion something and right breast lesion, right breast also is showing some lesion. We also did a contrast enhanced mammo for her, which I actually like seeing because it suppresses everything else and shows us the tumor. This is how clinicians like to see the mammo best, because everything else, my friend Aparna told me that you forget the MRI, directly go to subtracted image and just see your subtracted image and that should serve your purpose. So this is how we like to see the mammo. So I recommend CDM, but the science, of course, you know better. So the CDM also showed a similar lesion in the right breast and slightly more in the form of satellite nodules on the left side. The biopsy from the left breast was ILC, grade 2, ER8, PR3 and HER2 negative, and all the report was available. The contralateral, so we had an MRI. We must have had a discussion at that point of time. This is ILC, should I do an MRI, should I not? It's a relative indication, whatever. But the lady was keen on conservation, there were bilateral breast lesions, so we went ahead and did an MRI. The negative predictive value of an MRI gives me immense satisfaction at the end if the report says so. It shows something, then I'm unhappy, but that is a point apart. So if a negative predictive value can be utilized, it increases a surgeon's confidence in offering breast conservation in complex situations like this. So when you have a right breast lesion that was also there, so now we have three things. We have a speculated lesion in the left breast, we have an irregular lesion in the right breast, which is also BI-RADS 6. By then we had done a USG guided biopsy of that too, and something additional. Also in the right breast, which was like a non-mass enhancement, which is enemy, it's my enemy, but we have to still follow and trace those reports. So we did a USG guided biopsy from the right side and clipped it, and that's the clipping, and the right was IDC. So when we have an ILC on one side and IDC on other side, and there was a clip, we could have put a wire, but our radiologists are often able to provide us a surface topograph like this, based on which we can plan surgery. And this is the distances and the distance from the NAC and everything that we have. So we had a palpable ultrasound detected lesion, which was sono-localized. And then I had an idea about where the enemy or the extent of enemy was. So if you saw the patient's pre-chemo, pre-surgery picture, she was large and ptotic, so we decided to do a bilateral reduction mammoplasty for her. This was the surgical plan. This is where the tumor was on the right side. On the left side, I'm sorry, so the extent of resection was going to be this much. This is how much was the extent of resection on the right side, depending on the imaging and sono-localization. And we ended up with specimen mammography to confirm that the right-sided clip is out, and of course you can't see the enemy, but you could see the lesion which was seen on ultrasound, and that's the bilateral reduction mammoplasty that she has had on table. We had a good histopath. This is the pre-op picture, this is the post-op picture. Patient is quite happy. This is post-op 2 weeks picture. And the histopathology report, which says that she required only endocrine therapy followed by bilateral radiation and tumor bed boost. again, when you have a situation where there's more than one lump. So this is the case. I hate to see this mammography because you can't understand anything. You can only palpate where the tumor is. So this was a time of non-CEDM. This is 2018. So we did an ultrasound. An ultrasound had more than 4 lesions, and the patient was hell-bent on conservation. I'm sure Pallak remembers the name of the patient as well. And this is how the MRI looked, that there were multiple lesions. She told me very confidently that the MRI is restricted to 1 o'clock to 4 o'clock, and the rest of the breast is free. Like I said, the negative predictive value of the rest of MRI can be utilized very well. It was a triple negative breast cancer, but it was multifocal, clinically node negative. We decided to go ahead and take out all the areas of tumorous involvement. And this is how the preoperative sonolocalization picture look. I have lost that strip of paper on which we drew it, but the additional lesions were marked in this manner. And the patient had a wide excision of all of that and an LD flap. And these are the pathologists who are then meticulously telling us, this is tumor 1, 2, 3, 4, 5. And hooray, we have clear margins. We have one node positive. She gets her chemo and radiation subsequently. She has a RAD51 mutation. She underwent a laparoscopic oophorectomy for that as a risk-reducing surgery. The proof of the pudding is in follow-up of the patient. So the fact that she has still been coming to us for last 6 years is enough proof for us that the surgery that we offered her and all the imaging evaluation was spot on, and we were right. So in situations of BRCA mutations or triple negative tumors where more and more we are using chemotherapy, paclitaxel, carboplatin, and all the fancy chemotherapy, pembrolizumab sometimes, and the tumor is completely disappearing, there is a clip. This is a situation I do recommend putting a clip in because it helps to focus your resection area where otherwise you would end up excising more, and that's exactly not what you want. And PCR, and then all you have to do is radiation. Even bilateral triple negative breast cancer, again BRCA mutated patients, you have 2-sided tumors, you have put clips on both sides. So this is again where radiologists help us by putting the clips maybe at the same time of the biopsy after 2 cycles or whenever they think it's appropriate. And we do little surgery for her. We just have a specimen mammography of the clipectomy that we did. She has bilateral PCR, and then she's on surveillance because she chose to have BCT at the age of 25, which is fair enough for a BRCA mutated lady, and radiation. Whereas you have a scenario like this where it's multicentric, where there's no discussion on breast conservation, and we know that we have to do a mastectomy and hand over the patient for whole breast reconstruction by our microvascular team. Sometimes we see a multifocal tumor again and need not a regular BCT, but a little larger area of resection, and again, latissimus dorsi flap. I can discuss a few more cases like this, but in want of time, I won't do that. But all I'm saying is that whenever there are impalpable lesions and surgeons can't feel anything, obviously you need to depend on your radiologist to localize it accurately for you with ultrasound, with mammography. In one patient, we had 2 lesions. One was seen on ultrasound, one was seen only on mammo. We put one localization with ultrasound and one wire. Both were biopsy proven on table positive, and she had an MRM because of that. And a few more cases where specimen mammography is done, patient is keen on conservation. Extreme oncoplasty situations are often more and more practiced nowadays. And this is again a reduction mammoplasty for a large ptotic lady. So the goals of modern breast surgery is offer breast conservation whenever feasible, and obviously oncologically have safe resection, restore optimal cosmesis during breast conservation surgery. And what we want from our radiologists to be able to plan all this is accurate identification and BI-RADS of all palpable and impalpable lesions, discerning multifocality from multicentricity, image-guided biopsies, clip placements wherever necessary, pre-chemotherapy clip placement, especially in triple-negative breast cancer, and at the time of surgery to really be able to localize it either with a surface marking topo, with bracketing or whatever else fancy that we need to do, but we need to have confidence that we are going to excise all the tumor-bearing area. And we are not just some clinician and radiologists who are passing the buck onto each other for the case, but we are helping each other. There's extreme cooperation between surgeons, radiologists, and pathologists are required. Occasional fights are allowed. It doesn't affect our relationship, and the patient is at the center of all this. And that's our DMG, and thank you for listening to my bantering for so long.
Thank you very much, Alaka. That was very comprehensively and concisely put in. And I think what she has highlighted very much is that breast conservation is an extremely doable procedure with good collaboration with the radiologist, pathologist, and the surgeon, of course, with the patient being the center of the whole action and activities. And the second thing is in locally advanced also, if you have selected the cases well, we can do a breast conservation very safely. If anybody has any questions or queries, we'll be open. Maybe one question anybody wants to ask. Or she said everything that had to be said. Looks like.
Speechless.
Right.
I will invite our next speaker, and I have the honor to call Dr. Dushyant Jaiswal. He's a professor in plastic reconstructive surgery at TMH, and he's MCH from KEM in fellowship in reconstruction TMH, and obviously has keen interest in breast reconstruction, oncoplastic surgeries, and use of the imaging with the same. So I think that makes us more alert about it. And he'll be discussing about the imaging of breast reconstruction, what a plastic surgeon wants. Over to you, sir.
So, good afternoon, everyone. As is clearly declared in my talk title, I am not a radiologist. Honestly, I understand very little about imaging, but I understand exactly what we need. And what I'll try to do today is give you a clinical perspective on why we need what we need and how you can help us. So I'll be dealing with only the whole breast reconstruction part. And this is what the situation is after mastectomy and no reconstruction. But I think every patient has a right to be offered reconstruction. They take it, they don't take it is a different issue altogether. Because rather than the first slide, this is what we can end up with. So this is a variety of patients with different breast sizes with exactly matching reconstructions on follow-up with a variety of flaps. Now, there has been a long journey how we have reached here. I'll just recount it. So the donor options, when we look at, abdomen is 1 to 10. And everything else is honestly for whole breast reconstruction, 11 onwards. So abdomen is the site. And there is data to prove that when you use abdomen as a donor site for whole breast reconstructions, the outcomes are exactly same as a cosmetic abdominoplasty. Now, anatomy is very essential to this whole concept. So the rectus muscle has a codominant supply from the superior epigastric artery and the deep inferior epigastric artery. And from the deep inferior epigastric artery, perforators emerge and supply the lower abdominal fat. This is the dominant source. And that skin and fat can be harvested from it. So the evolution has been such that after attempts were LD and all were abandoned basically due to donor site morbidity, lack of volume, and not really vascularized flap, pedicle tram really took off and established the stage for breast reconstruction. Now, pedicle tram is based on the superior epigastric, which is not the dominant supply. So you can occasionally get very good, excellent results, as good as anything with pedicle tram, but here is the problem. So this was the first contribution of radiology to the understanding of breast reconstruction. So what happens is that the superior and deep inferior epigastric vessels in 60% of patients don't communicate at all. So what you're depending on is the choke vessels to open up and a dynamic circulation opening up, which also doesn't happen often. So this is what we would end up often with. A lot of partial necrosis, if not total necrosis. But in breast, partial necrosis, which needs to be debrided and closed, is as good as a total loss because the whole idea of an aesthetic reconstruction is lost. So the next stage in evolution was to use the lower abdominal fat based on its dominant supply as a free flap. So this was what was called the free tram flap. So a free flap is essentially harvest of a tissue from anywhere in the body with its artery vein blood supply, disconnection, shifting to a new site, and restoration of the blood supply by microvascular anastomosis. So it's essentially transplant without the hassle of immunity problems. No. So from the pedicle free tram, the issue was the morbidity. You're taking the rectus muscle, rectus sheath. There would be bulges, there would be hernias, there would be abdominal weakness. So the natural evolution was if you take only the perforator. So the deep inferior epigastric perforator flap evolved from the tram. Now you'll hear this term perforator often. What essentially is a perforator? So perforator is sort of an end artery which pierces the fascia fat and supplies the fat and dermis. So this is a recurring theme in all plastic surgery work. So now currently the gold standard most often done autologous reconstruction is the deep inferior epigastric perforator flap world over. And as they say that all you need is a perforator and then the flap is on. So whenever a breast reconstruction is being done, there is a primary aim of achieving a cosmetic outcome with the least partial or fat necrosis. These primary aim has to be achieved by matching contour and finding the best perforator. The secondary aim is to minimize the donor side morbidity by leaving behind all the muscle sheath, preferably vascularized and innervated. So now when you compare all these flaps on the abdomen, DF has the least morbidity and variable vascularity. So what happens is, as we evolved to the DEP and started choosing a perforator, so we were essentially leaving behind one side perforators totally and a lot of perforators on same side. The vascular problems of pedicle tram returned. The donor side problems of the free tram and pedicle tram was solved. So surgeons responded. So this was the vascular problem. So essentially it was attributed to midline crossover not happening naturally or due to scars or inappropriate perforator selection. So it took a time for the surgeons to reach here. As two surgeons, we first blamed the anesthetist for hypoperfusion. Then we blamed the radiation oncologist for radiating the breast. Not only that, we even blamed the radiologist for picking up too much insignificant fat necrosis. But then better sense prevailed, and the realization came that the problem is vascularity and inappropriate selection of perforators. So so the fat necrosis rates, subclinical fat necrosis rates were still there. So once this realization came, we responded as surgeons would do by more surgery. So first response was to harvest more perforators from the same site. It didn't seem to make much effect. The second response was to harvest one more perforator on the other side. So you would have a bipedical flap, one perforator on each side, and then you anastomose both of them to each other or to a single source vessel. But the real revolution came when the realization dawned that there's something is wrong with the selection of the perforators or the cases. So every expedition needs a direction, and our direction came with imaging. So there is almost equal evidence that all three things work equally well when it comes to imaging for DEP, but CT, for the reasons of logistics, speed of acquiring images, was deemed the best. And most importantly, CT gave us all we needed. MR gave us brilliant images to look at, arborization and all was right, but the time of acquisition and all was problem. Doppler ultrasound, obviously user dependent. The surgeons could not interpret it really. So the standard is now CT imaging. Work is going on other fronts also, but CT is the thing which I think should be the starting point for all DEPs. It has made a huge difference. What CT has done is not only for the patient, we have had better vascularized flaps. For surgeons, it's made an even bigger difference. We are much assured, our surgeries are more efficient, the fat necrosis and partial flap necrosis also have reduced, and there's good large volume evidence to this. So Dr. Abhishek and us had published some of our work where we had 80% concordance between CT and imaging, and a lot of technical details have been outlined in the paper. So when we look at imaging, what do we essentially need? So what I am interested in is in points with which I will actually take a clinical decision. So I'll just run through these things one by one. So this is the first point which is often reported in all CT images, the branching pattern of DIEA. Type 1 if there's one vessel, type 2 if there are two, and type 3 if they are multiple, and type 4 is also described. But this actually doesn't give me any clinical information because I am not approaching the vessel from the external iliac up. I am approaching it from the perforated down. So this is chart where I summarize exactly what I need to know. So I need to know the size. I need to know the cause through muscle. I need to know the relation between the midline rectus muscle. I need to know communication with the superficial venous system and the midline crossover. So what we have come to is, I don't need a perforator, I need the perforator in the abdomen. By the, I mean the most representative, largest, best arborizing, and one which owns the abdomen. Okay. So by the, I mean the large, it should be single, preferably paramuscular or having a small or intramuscular long preperitoneal course. The relation as more to the midline, better for the muscle preservation, has good communications with the superficial system and has a good midline crossover. But the truth is sometimes you will have a configuration where you will have multiple small intramuscular courses. But this knowledge is also important because if I am not able to do a DEP flap, the awareness that a DEP is not possible in this would help me harvest a tram or an MS tram faster and save a lot of anxiety because ultimately I can still reach the same cosmetic result with a little abdominal morbidity. But still the result is the morphology. It's not the imaging or what anastomosis I have done. So this is what my interpretation is. It's a medial row perforator. I would rather call it a medially placed perforator, which is going laterally, the harvest on it. So this is the dream situation, paramuscular perforator. So this is essentially something where there's no intramuscular course. The perforator directly goes preperitoneal to the external iliac. Now this is the single most reason why I love CT scans before a DEP. Because if I don't have a CT scan, I would have to cross the whole rectus muscle after the incision to find a perforator, and often it will end in a situation where you'll declare that there's no perforator, and you'll convert it into a pedicle free tram or pedicle tram on the other side, and it will not work because you have missed the best perforator. This is the lateral row perforators, which work better when you need to do a bipedicle or a bilateral flap. So now next is the course. One, you have chosen the perforator. So essentially every perforator have these three elements. First is the preperitoneal or submuscular course, then the intramuscular, and then subcutaneous course. But when you are operating, you see it in the reverse order. You see the subcute or suprafacial part first, then the intramuscular and preperitoneal. One very important thing which helps us is this subfacial course. So sometimes what happens is the perforator dips below the sheath and then has a long course. So when you are opening the sheath, the perforator is actually more susceptible to injury. So if I have the knowledge that it has a subfacial course, I can be prepared. Another configuration, what happens is in type 1 vessels, there are sometimes multiple perforators which are arising from having subfacial course and actually joining the DIEA at a single point or in one line. So what it means is I can harvest a more robust flap based on the same morbidity based on my CT knowledge. And the last bit is the subcutaneous course. So subcutaneous course is something which a surgeon cannot see with his eyes. The rest three in the course of dissection you can always see. So what the subcutaneous course tells us is the one showing the arrow is a medial perforator. So it is closer to midline, likely to have a better arborization. And one on the other side is placed very laterally. But if you look at the sheath level, it might almost be in the medial row. But this will not have a good crossover simply because of its location. So now the need for the midline crossover tells me the need for a bipedical flap. When it's absent, you need to do. So midline crossover is essentially important to know this, that how much of the flap will survive on the given perforators. So this was an era where a lot of these zones were discussed 1, 2, 3, 4. With the advent of imaging, most of us have given up talking about in zones and actually depend on the amount required and how the perfusion is likely to be. Next comes the venous drainage. So venous drainage mostly follows the perforator. The lower pannus, often the superficial is dependent on the superficial veins, but mostly you don't include that part. Occasionally, there is a split drainage where the superficial fat is drained by the superficial system. This is where we need to have know in the CT if there is a very dominant with no communication, because this will have disastrous clinical consequences. Occasionally, you have this situation where the SIA or SIV are the dominant vessels, and there is no communication with the DIE and there are no perforators. So in this case, you are not going to find a perforator. You have to depend on the SIA, SIV. It's a very rare situation, but done. This is something I try to see what is the thickness of the rectus abdominis muscle. So what it does is it puts into perspective that is it really worth doing a DF flap when you have the total muscle width of 4 centimeters and thickness of 2-3 millimeters or very thin. So you have a low threshold to converting to an MS tram because there is no muscle really to cause any morbidity. The next place where imaging helps is the donor vessel options. The most common is the internal memory, artery and vein. So what an imaging does is it tells me the number of veins and artery, their presence, their relation to the sternal edge. It tells me, it can also tell me the course in the third intercostal space. And it also helps us know if there are too many lymph nodes, fibrosis or any absence. So now we also use the internal memory perforator in lots of cases where it is as large as a pedicle or it declares itself. Now this is also something which we can know from a CT scan. The last bit, which is often not reported or is still a work in progress around the world, is the morphological assessment. So what it does is, if you see these images, you can get a very good idea of the thickness and the amount of tissue which will be available in breast and abdomen. Now what happens is if you have a very, so what happens is the breast size you see is laid on the chest wall projection. Sometimes the chest is not very projective, the rib cage, and the breast appears suspiciously small, but it's actually larger in volume. And the abdomen with a lot of intra-abdominal fat appears big, but there is actually less tissue. CT actually tells this very well. So this is not the radiologist's work, this is just me playing with the arrow toys. So I do this exercise just to give a gross idea of how much volume is there in the abdomen and whether I need to take the whole pannus and the subsequent bipedical flap or multiple anastomosis requirement. Very importantly, as surgeons we have blinders on. If we want the perforator, we are looking only at this. But we want the radiologist to report on all these things also. We have had cases where actually imaging for DF has reported mets in the liver and spine, and the patient has been spared unnecessary surgery. So just a few case examples how it helps. A 60-year-old lady with a large chest wall defect had a very large abdominal pannus. And imaging, there was a nice big direct submuscular paramuscular perforator, which we harvested the entire flap on. So zero morbidity, and we could cover her. The intent was not really reconstruction here. Another lady recently operated, very large skin excision, had a big, needed the whole pannus and likely bipedical flap. Now on imaging, if you see, my natural inclination to mark this pannus would have been in red. But on imaging, I realized that my perforator is at the edge or above the umbilicus on one side, and I needed a bipedical flap. For me, this is the single most important reason why I need a CT scan. Because if I make it too large, my pannus, it will lead to donor site morbidity. If I don't place it well, I will miss the perforator or its arborization. So we did a bipedical flap for her, saved all the nerves and muscle, and decent results. It's early days. Now in a bilateral mastectomy with bilateral DEP, I am worried about a configuration where there is one big perforator on one side and nothing on the other side. So again, your imaging becomes important, because if you are aware it is not there, you can do something else. It also forewarns us that there's a single perforator on each side, and no injuries are possible. So this is another lady with a bilateral DEP and result after reconstruction. Now again, this lady who had a secondary reconstruction, she actually had a vertical midline scar. Now you'll obviously be fraught with this thing that there might be injury to the DIA or no circulation, plus it's a secondary reconstruction on one side. But CT scan gave us an all clear, and we did a mastectomy with nipolariolar graft and bilateral DEP in her. So it's not just DEP, even for the alternative flaps, it's all the more important. Like this lady who didn't have bulk in the abdomen, but adequate in the gluteal region. So did a S-gap flap, and the CT told us where the perforator would be. Or in this young girl who we did a lateral thigh flap, again, the CT told us exactly how and where the perforator would be. Now, this is the last case, a young girl who had a large chest wall defect and needed large skin replacement. So here we knew that there is both a TFL perforator and an ALT perforator present. So we could harvest a chimeric flap comprising of ALT and TFL and maneuver this into a nice mound and breast reconstruction. All is good, but there is some places where we can improve. So essentially, it doesn't tell us what a Doppler does. And it also doesn't tell us the dynamic things, that what will happen when we'll incise. Will the choke vessels open up? How the microcirculation is. So perforators generally not mess with the modern imaging cuts and all. It's okay. Sometimes we have a lot of patients who have had an LSCS earlier, and there is unanticipated, so to say, fibrosis. So if imaging could tell us, it will be good. I had one case where we started a bilateral DEP. The CT scan, I thought perforators are there. The report was also positive, but there was a big transverse scar on the sheath, and all the perforators were transected. And we had to abandon the surgery, obviously. In retrospect, when we went back and talked to the patient, she had an emergency LSCS. So I guess the clinical picture has to be always taken into account. And I was wondering that why did we get misled in the CT? So what must have happened is from the dermal circulation and other vessels, the part of the perforator must have been a retrograde fill. And the one cut where we could actually see the suture or transection was missed. So to summarize, we need a good CT scan, which I think you know better, with nice fine cuts. It gives us vascular anatomy and morphological insights. And for a surgeon, it makes our procedure faster, surer, stress-free, a much shorter learning curve. So this has been one difference. I've been able to teach DF flap much faster to my residents since we started doing CTs. Because the surgeries turned out much better planned, and there was no need for surgical chutzpah, so to say, while harvesting. Or in a simple sentence, perforator is the treasure and CT imaging is the map to it. Thank you.
An excellent talk, Dushyant. That was brilliant. And I think you highlighted the role of radiologists being an essential component of our planning, not just, as Shalaka said, for the breast conservations, but the reconstructions, I think we really need them much more. Because at least in conservations, we are able to look at our mammograms and ultrasounds and CDMs, we are able to manage, correct? But with you, I think it's a very essential component because the success story comes only with the teamwork with the radiologist.
Absolutely.
And
Yeah.
Asif, I think you want to say something.
And I wanted to know, do you use on-table Doppler?
Okay, I don't, and I have a reason to it. So I think what has happened is CT gives me everything in a DEP. I
Okay.
don't really need to. So most of the times people use Doppler is to assess the course or if there is an injury or to secure a perforator. So my take on it is that, see, there's no alternative to nice, safe, clean surgery.
Right.
You can use all the Doppler, you can pour all the papaverine, lignocaine, vasodilators. It's not going to revive a perforator if it's died. So I don't use, but, and I honestly haven't felt the need since we had good CT imagings, for DEP at least. Yeah.
You showed such excellent cases. I just wanted to know the CT coverage for you, what is minimum required for you? In this.
Okay, so basically I am looking for the internal memories from the subclavian,
Okay.
and I actually prefer it till the knee because
Okay.
it gives me an image of the thighs also in case there is an alternative plan,
Fine.
or if I need to take an ALT, TFL or one of the uncommon S-gap or PAP perforators.
Fine.
And that's it.
That will help a radiologist, I think. Thank you.
Yeah, I guess a very good planning, which is done much in advance, and knowing that there can be an issue or a concern, and you may have on-table problems, and surprises are never good for us because especially patient has been induced with the thought that she's going to wake up with a breast.
Yeah, yeah.
It's very not nice at all to have to wake up and say that
Actually,
no, we
there are
failed to
times
do
when
it.
I have not chosen a DEP based on CT. Patient has an abdominal scar and both sides of perforators are not good, or they are too high, will not come in the panis. Somehow you don't capture and keep those CTs, but we have taken decisions based on imaging, clinical, that abdomen would not be a good idea.
Small question. You showed some markings done there, which you do, but that is based on your CT information, or again, do you use some kind of mark?
On the abdomen?
And
No, it's
abdomen?
used on CT. So we do a very simple thing. So while scrolling, we see the numbers of the umbilicus from start to end. We find the umbilicus, and then we see at what point the perforator is more prominent, and then we measure it on the CT with a scale.
Right.
And we just replicate it on the abdomen. You can confirm it with a Doppler, but it's okay, because what happens is, say, you're not doing the whole procedure blind. At some point, you have to see the perforator and incise the sheath and chase it. So that is almost what is needed. It works for us.
I guess it just gives you the caution area.
Yeah, exactly.
More than anything else. And I think for a learning person who's training or learning,
It's
having
excellent.
a Doppler
Absolutely.
at the same time to confirm on table is kind of reassuring for them to know that what you marked on CT is also reconfirmed
Yeah,
on Doppler.
absolutely. For a
For
learner,
them,
it's fine.
not for you maybe, but yeah, for the beginners, yes.
So the
Yeah,
biggest
thank
problem
you.
I actually face is, will the CT open in the OT?
Another midnight call situation.
Yeah. So my midnight
That's
call is to
early
the
morning.
resident.
That's
Is the
more early
CT done?
morning call.
Is the CT done? Okay.
Right. Thank you so
sir,
much.
So what we do is we have the software. I mean, most CT scans have. So we just superimpose once the point is chosen, the surface marking grid map with a 1:1 scale is pasted on the point of location of the perforator. So it gives a topogram of the where it is. We take arteriogram phases also. So it's a triphasic scan. And we are trying in discussion, we are yet to start, instead of the routine arterial phase, we were thinking of keeping an ROI along the external iliac artery so that we have even more better opacification
Fine.
than a general protocol. So we would probably look at that. Just one sentence
Yeah,
I wanted to say, for the residents over here, which I didn't know when I was a resident, how many hours does it take for your surgery? I know it now. And it is very
Okay.
easy to one line to say stress-free, time-saving. You have to go to the
So-
OT to see what happens for that one perforator, the amount of time it takes, and to have that necrosis and all those 10, 11 hours of surgery. Which,
No, it's not that much. So I'll give you a range.
Yes,
So if I have to dissect one perforator, I mean, apart from cutting the tissue and raising one perforator of DEP harvesting is 1 hour at least. But it could be 2 to 3 hours also, depending on the course.
starting to finish, the overall.
No, this is the harvest. The whole process is a whole day.
Yeah.
So after, if Shalaka has given us the case at 10 o'clock, 2 o'clock if we finish, it's super fast. 4 or 5 o'clock is decent, but often it is 6 to 7 also. It depends on the person and level of training.
Yeah, so brilliant.
Bilaterals are 9 o'clock.
Bilateral is midnight again.
So-
Call by me. At
So that's
midnight.
because you can't divide both the flaps together. So abdominoplasty and all, but that's okay.
So just one thing to add, which I was discussing with Palak and the AI booth outside, is that 3D mammography or a three-dimensional view of the tumor, where like how you do in liver. Sir must be knowing, and Nitin. So I've been telling everybody since I guess now 7-8 years that I want a mammo to rotate, and I don't know how you do that. That's not my problem. And tell us the exact. Sorry, I mean I'll be honest about it. And tell us the exact extent of the multifocal multicentric tumor. I was at SO for a conference, and I was telling you outside also that there is a company called. I'm not promoting them in either way. I have no shares, but it's called, what is it called? Avatar Medical. And it started, and there are stakeholders who are surgeons only, by the way. And they wear goggles, virtual reality goggles, where the MRI, CT, mammo, whatever is done is integrated in that. And the operating surgeon wears them and looks, and that in virtual reality shows them a red tumor of the impalpable area. So, I mean, I'm not saying we need that, but it's just a dream situation, like a dream perforators, that we could have a situation like
So
that.
I will, Shalaka, let me add to that. Let me add to that. While your dream you think is a dream, you can attempt working with our 3D printing lab at ACTREC, because we have a software for 3D imaging as well. And you can actually have Akshay work on this, because we have our CT images. Akshay is a 3D printing person who is there at ACTREC. So you can attempt doing that, because there are images, and he can convert the images into an image that you can play with, turn it around, and get your planning also. Try it out once.
So, Palak, can I add one thing to it? So there is a lot of imaging going in plastic surgery. About ALT, lymphedema, whole development is directed with imaging progress. So what I came across, have you heard of the Mitaka's projection system? So what they do is basically, so the problem is that you have an image on screen. How do you get this image on the screen? So they have these projectors which actually project the image on the patient. So they have markers and all. Yeah, so they are doing this for a lot of reconstruction and lymphedema work also. So I think that would be the next logical step. So it's like practically you can see the perforator on the patient, and next probably maybe we'll have a robo who will dissect it also for us.
Father Muller Medical College and Hospital, Department of Radiology. Her areas of interest include breast imaging and women's onco imaging. She's MD, DNB, EDIR, and has done a fellowship in breast imaging at Tata Memorial. And, working as a breast imaging and intervention specialist at FMMC Mangalore. She's the first so-trained radiologist in Dakshin Canada and North Kerala. Happy to have you here.
Thank you, ma'am. Good afternoon. I think I'll soon be saying good evening, but then I'll have to rush because of lack of time. So my topic is imaging-assisted pre-surgical planning for oncoplasty, and I'm very thankful to Shalaka ma'am and Dushyant sir because they have covered actually more than half of my work. So rushing through, like they have told that there will be a DIP flap and a latissimus dorsi flap, which they will be using commonly. And for a DIP flap, the same thing I won't be repeating. The most important sections will be your axial imaging and your sagittal imaging, MIP images, so that you can see the whole course of the perforator. I'll be skipping which has been already covered. So these are the representations where it's been mentioned that the subfacial has to be of mention. Even the intramuscular course, I think we always mention whether it's a perforator or it is the DIP vessel per se. In the intramuscular course, it's important to say whether the course is less than 4 cm or more than 4 cm, because less than 4 cm considered as short, more than 4 cm considered long, which is again not an ideal perforator, not the perforator. And the measurement is usually done in a sagittal section, the length of the perforator, its course in the intramuscular route. There's one more thing, like there's paramedian. Again, paramedian is also, again, they love the lateral course of the perforator. Paramedian, again, it's difficult to dissect, and hence it has to be mentioned in the CT report. The other thing is a tendinous insertion, which is going to be a difficult dissection along the fibrous sheath. So this is better appreciated in your coronal sequence. Usually these CT angios, so what we do is when we have these MIP images taken, then we do this volume rendering, and then we increase the surface rendering, like from volume rendering we go to a surface skin surface rendering, and then we get the image of the skin, and then we open all the sequence and we choose the ideal or the dominant, the perforator, using a 3D cursor, and that same thing will be represented over the skin surface. And once they are assessed, we take the measurement from the nipple on the either side as well as below, and we mark them as dominant perforator 1 or dominant perforator 2 on either side, depending upon the caliber, the course, and whichever satisfies the ideal perforator definition. Then we have this latissimus dorsi. So like ma'am had said, that probably for beginners it is very important because they would like to know the latissimus dorsi Doppler. So what we do is we keep the patient in the supine position, arm above the head, and you need to trace the axillary artery. And once you get the axillary artery, the first vessel that drops down will be a subscapular. As you go down, you get the branches of the latissimus dorsi. These branches of these latissimus dorsi is predominantly medially and caudally. So it is a fan-shaped perforator what you get, and these perforators can be marked on the skin. This is one of the role. The other important role is we need to tell the extent of the disease, because this is important in 3 things. One is distance from the index mass. Second thing is the total extent of the disease with ratio of the breast volume. And third is to screen the contralateral breast at the same time, because this changes the management both for the patient as well as for the surgeon. So there are so many modalities. Like for mammography, we use topograms, which the image will be shown later. There are stereotactic wire localizations, which are used for either your clip, or which is post NSCT because it's non-palpable, or for your microcalcifications, again, which is non-palpable. Then biopsies, stereotactic biopsies will be again diagnostic method. Ultrasonography we use in TMH sono localization, which is a method where we use the probe. I'll be showing how do we do the technique. And again, ultrasound guided localizations. And these contrast studies, we have CEM and MRI with respective biopsies with clips. So these are used for non-mass enhancement, where you don't see any correlate on ultrasound or mammography. The last important is the most important thing that you need to communicate, you need to discuss, because it is based on the patient, based on your findings, and based on what the patient wishes for. So these are case scenarios I'll just show. These are learning session. Because most of it is already covered, I'll just run through some cases, and I'll show how a sonolocalization and all we do. So this was a 40-year-old premenopausal lady. Right, locally advanced breast cancer. We can see a spiculated mass, architectural distortion reaching till the skin, and there are pleomorphic microcalcifications in segmental distribution. This was an IDC, grade 3. Post-chemo, we can see the mass is resolved. It becomes impalpable. However, the pleomorphic microcalcifications are more consolidated and more prominent in post-chemo because there is decrease in the density of the mass due to necrosis. So this was planned for a preoperative localization of the index mass, and she was planned for right BCS with specimen mammogram for calcifications to see the margins, and an oncoplasty with chemoport. So this is how we saw on sonolocalization. So this was the post chemo changes seen in the index mass in the right breast. So we can see there is architectural distortion. We usually give distances: 1, distance from the nipple, then 2 is minimum and maximum distance from the skin, like this image, where you release the complete compression. So there are 2 things you need to remember. 1, when you put the probe, it has to be on the shortest distance, because you can see the lesion at 90 degrees from either side also, you'll be able to see the lesion. So the shortest from the distance, which is usually perpendicular to the lesion, you need to hold the probe, release the compression till you visualize it. Once you release the compression till you visualize it, you will get the minimum distance from skin and maximum distance from the skin. So this is the depth which they go, and this is the depth which they go. This is more important in benign lesions, because in malignant lesions usually they go till the base. But in benign lesions it's important, especially in fibroadenomas, because they are mobile, and the depth can be missed, because sometimes we give a lot of pressure and fibroadenomas can be visible probably with the 2 centimeter, but when you release it's actually 4 centimeters, and then you can miss a sonolocalization excision of a fibroadenoma. So in these cases it's important. The next thing is, this is how we give a clinical picture. So this is of another patient. So we take the index mass and we draw the additional lesions. So here I want to add a note. When do you call it as a satellite? When do you call it as a multifocal or a multicentricity? Satellite nodule, we usually, it's not a defined, it's just an added term what we use to communicate. Satellite means in the vicinity of the index mass, there are multiple nodules which are there. Important is multifocal or multicentric. So what happens in multifocal is you need to see, definition wise, it means it's only in one quadrant. Multicentric is in multiple quadrants. But sometimes a multifocal lesion, which is 5 centimeter away, in a large breast, can still be within one quadrant. And of same, a 3 centimeter apart from 3 centimeter distance from the index mass and the additional lesion in a smaller breast can be again a multicentric. So it is all case basis. The other scenario is, suppose if you see a retroareolar or a periareolar 12 o'clock and 6 o'clock, which are probably 5 centimeters away. Ideally it is multicentric, but if you're doing a central quadrant BCT, then it's going to be a multifocal. So it all depends upon the level of the tumor size, the location, then the distance between the lesions, then the patient breast thickness, as well as what surgery is she opting for. So this is how we draw a topogram for calcifications on a mammogram. Like it is a post NACT where we draw from the nipple. So this is the index mass which we have drawn on sonolocalization, and this is the course of calcifications extent which we mark so that the surgeon can know that how much of distance they can take the incision and how deep they can go, like 8 centimeters deep from the nipple. So this is another case, 45 years premenopausal lady with the right LABC. You can see her irregular mass with calcifications, multiple pleomorphic microcalcifications seen inframedially. There is another morphologically different grouped inner regional distribution calcification seen, coarse heterogeneous. When we did an MRI was asked for it, and on MRI, the whole of outer aspect, there were multiple, there were lesions as well as non-mass enhancement which was seen. And for that, there were two options given to the surgeon. One is from the index mass at which we usually sonolocalize. From there, you can either go 7 centimeters deep on table, you can take a frozen and see if it does not come as, if it comes as positive, then it is disease. The other option is to go for an MR VAB of the NME in the outer quadrant. The patient was keen on conservation, so hence an MR VAB was as asked, and it came out as a high-grade DCIS, and hence she went for a right MRM with axillary clearance. So in this case, I think it was already shown the right-sided focal asymmetry is of interest, and the left side was an IDC. There is enhancement, abnormal enhancement seen in the right side in the perioral region. CM guided VAB was performed for it because it was enhancing, and post NACT, like I said, it becomes liquefied. The left side showed changes with pleomorphic microcalcifications being prominent. Right side, there was no change. So what happened was, in the mammogram right side, when you saw the focal asymmetry on ultrasound, there was no correlate. But post NACT, because seeing the changes on the other breast, we thought we'll do an ultrasound and check. And when we did an ultrasound, we saw an area of hypoechoic ill-defined area with architectural distortion, which we thought could be the residual necrotic component of the previously undetected or occult lesion on the mammogram. And it showed on the right breast, there was no residual viable tumor. And for the left breast, which underwent simple mastectomy, there was the residual invasive micropapillary carcinoma. That was sonolocalized and it was excised with clear margins. So this case, here the right breast looks unremarkable. Left side, it was an ILC. When we did an ultrasound, we saw in the right side, which was indeterminate at retroareolar 6 o'clock, indeterminate for a cyst or a solid nodule. But however, because of its consistent hard on elastography, went ahead with a CEM. And on contrast enhanced mammography, there were other multiple enhancing foci, both in the upper and lower quadrants of the right breast. Then when we did an mammography, because it was contralateral ILC, which was confirmed, it showed all these multiple enhancing foci were actually lesions. It was multicentric, and hence patient was given two options: either go for an MR guided biopsy and proceed, or we can do a sonolocalization of the retroareolar 6 o'clock, do a frozen, and then we can take a decision based on the frozen report. Sonolocalization was performed for the lesion, and on front table it came out as an invasive lobular carcinoma. So she had bilateral invasive lobular carcinoma, and hence she went for bilateral MRM with port. This is the other case. Again here, it is on the evaluation right side. Again, it is obvious. It is a locally advanced breast cancer with nodes involved. In the left side, it is a story about the microcalcifications. Two groups of microcalcifications, one at the lower outer quadrant, one at the upper outer quadrant. One in the lower outer quadrant was associated with the mass, with the calcifications within, so this was suspicious. It also had a correlated ultrasound, which turned out to be a left breast IDC. But the upper outer quadrant on the same breast has to be evaluated. Stereotactic biopsy was done, and a clip was placed, and that came as ILC. So she was IDC on one side, on the ipsilateral side. So on the same side, she was IDC on the lower outer quadrant, and the upper outer quadrant, it was ILC. So, and hence she was not willing for reconstruction. Bilateral mastectomy was performed. This case,
Surgeon, I think we have already overshot the time.
yeah,
So
just
if you
last
can just
case.
make it brief.
Okay, yes, ma'am. So there's one case, yeah, so this case, she had, on ultrasound, it was a morphologically suspicious lesion seen in the left side, the contralateral side, no enhancement on CEM. MRI, there was enhancing area along the same axis of 3 o'clock. This was the lesion, the superficial one corresponded to the ultrasound finding, and USG VAB was done, which came out as sclerosed papilloma. So this was one of the cases where CEM seemed more sensitive and specific than MRI. This is how we do an MRI for a non-mass enhancement. So especially in patients who have underwent a scar excision. So we use the scar and the sonolocalized marking of whatever suspicious lesion as the location along with the nipple and the midline, and we draw what are the centimeters for the DCIS, for which frozen was taken for this patient, and it turned out to be a DCIS. So she underwent a proper BCS. Otherwise, usually it will just be a revision of an excision cavity. Yeah, so sometimes what happens is we see the lesion on ultrasound, architectural distortion or any hypoechoic lesion on ultrasound, but we won't be sure like whether that's the same lesion that you see on mammography, because this was the lesion which was seen as an architectural distortion, area of architectural distortion with asymmetric density seen in the left breast. She had come for screening. We were not sure if that was the same lesion which we saw on ultrasound. So what we did was, and on ultrasound it was looking suspicious. So one thing what we did was we put a BB marker on the top using sonolocalization. So basically patient was on table. On the sonolocalization we did a skin marking, took her to the mammo room, and on the skin marking where we have marked, we put a BB marker, and then on compression we took it so that if that correlated well with the mammography finding, and then we were sure that that was the lesion what we are seeing on ultrasound. Yeah, so I think I would want to acknowledge the whole team of TMH ACTRIC breast department. There are colleagues, residents who had sent me images, Soumyashri, Atif, Renuka, Genesis. I really thank them. Thank Britt team and faculty, FMMC Mangalore where I am working, and my family. Thank you so much.
Invite for next talk, Dr. Purvi Haria. She's Assistant Professor Radiology in TMH, completed fellowship in breast imaging in Singapore General Hospital, and has special interest in breast and GI imaging. Purvi, over to you.
Yeah, thank you. Thank you for the introduction. I won't take long time, and so we've already got the base with Dr. Shalaka, Dr. Dushan talking about the surgery aspect, how we plan the surgery. So once the surgery is done, patient comes back to us for the post-operative, like we follow up those patients post BCS follow up, the screening that we do. So we are going to talk about that. In post, when we are doing the post BCS assessment, okay, so what I'm going to do is we'll just divide talk. I'm not going to talk about the surgical procedures, because we have to know what surgery has been performed, but it's already been covered, to know what we expect in post-operative imaging. So knowing about what kind of surgery has been performed, is there any replacement done in the breast, with what kind of replacement is done, is it just a subcutaneous fat, or is there a flap with a myocutaneous flap those things we need to know before we even put up those mammogram and start assessing, because otherwise we will end up calling something which is a normal post-operative appearance to something which is suspicious, and patient will go on for surgery. So a bit about a 2 or 3 line how the surgery is performed, what flap or how they've done reconstruction, what kind of oncoplasty surgery, how tissue has been mobilized inside the breast is something which we should look at before reporting this MRs. How do we do the surveillance? And we'll see the most important thing that we will discuss is imaging appearance of fat necrosis, because this is the only thing which we have to differentiate from the recurrent disease. If we know how fat necrosis will look, then we will, when it is not something which the appearance of fat necrosis, it is something which is coming up new, and we have to call that as a suspicious lesion. Okay, so let's move on. I will not talk about the surgical procedure, has been already discussed. Surveillance protocol and post-operative breast is clinical evaluation. This is breast conservative surgery, 1 to 4 times per year for initial 5 years, then annually. And mammogram is performed annually, starting 6 to 12 months post-therapy, which is post-RT. So now what are the changes that we expect in breast, which is fat necrosis? What happens pathologically there? So basically, fat necrosis is a benign non-suppurative inflammation which happens in the adipose tissue. Whenever there is adipose tissue injury, there is release of lipase which breaks down into triglycerides and fatty acids. So in short, there are 2 pathways. One leads to development of calcification, and one leads to development of fibrosis. This happens pathologically, and this happens gradually. It doesn't happen immediately in a first year post-surgery. You will not see some changes in first year. You will see subsequent mammogram, these changes, evolving those changes in the mammogram. So this is how fat necrosis evolved. Like, it can be fibrosis, it can be calcification. So I have a case here where serial mammograms are there from 2019, 21, and 23, CC and MLO view, just to show you how these calcifications are developing in the breast parenchyma at the post-operative site. So depending on where we are in the stage of fat necrosis, the imaging appearance on a mammogram can include architectural distortion or focal asymmetries or cystic changes. Sometimes it is mass forming also, and we can also see calcifications. So this is another case. This is 2019 CC and MLO view of a patient where there was this patient underwent a left breast conservative surgery in 2019, and we had done her mammogram in the end of 19, and we see this is a post-operative changes with a lot of surgical clips which are there to mark the surgical blood. When she came back in 2021, she didn't come in 2020 for a mammogram, or it was, and we saw that there was an increase in the density at the scar site. We did not like this increased density. We went ahead and did a contrast enhanced mammogram, and that density was not enhancing. It was just the minimal peripheral enhancement, which confirmed that this is not something which is suspicious or something which is developing as a recurrent disease, and we can observe this finding, and we can leave this, and we did not biopsy this finding. So this is the So when we go, what are the most common changes that we see is this dystrophic calcification. So dystrophic calcifications which are associated with the fat necrosis are almost always adjacent to the scar site. They are generally more than 1 millimeter in diameter, but this is not very hard and fast. It depends on which stage you're doing the mammogram. If it's a first post-operative mammogram, you may see them as a very fine pleomorphic calcification, which you might want to observe on a shorter duration and do a repeat mammogram a little early. They tend to coalesce on a subsequent mammogram. And as I said, they are, in initial phases, they are difficult to differentiate from the calcification of the recurrent disease. On ultrasound, when we see this cystic lesion as a, fat fluid level, which we see of the fat necrosis, this can be seen at the site of your, below the scar site. Sometimes it is seen, the solid masses are associated with fat necrosis are seen as ill-defined lesions along the scar site, and then often exhibit this posterior acoustic shadowing, which we might think that as a recurrent disease, but we have to see this with caution. Other changes that we see with postoperative at the site of surgery is postoperative seroma. Basically, this is non-infective serous collection, and this generally resolves in the subsequent mammograms. So I have an example. This is this patient, and this was a first postoperative mammogram, and we saw this isodense, hyperdense lesion along the scar site. We did the ultrasound for this patient, and which was clear fluid over there, and this was passed off as a seroma, and nothing was done for this patient. So as I was saying, the post-flap reconstruction, we should know what kind of flap is used for reconstruction. So now this patient is underwent right-sided breast reconstructive surgery with LD flap. So when it is a LD flap, it is a myocutaneous flap. We always see this additional layer of muscle in the flap, which is replaced flap. This additional layer of muscle is normal finding. It's not something which is developing something inside the flap. So we have to be very cautious about this. Many a times, if you have like multiple this LD flap, same patients, multiple mammogram over the years, you might also see this muscle getting atrophied over the subsequent mammograms as well. So that also is a, so those things also we can see on the mammogram. Now this is a DIP flap reconstruction. So post reconstructed breast, there is no need to do the mammogram because there is no breast tissue left. This patient, we did a mammogram because she had some complaint on the breast. She did complain of some vague, vague feeling of pain in the breast. That is why we did the mammogram. But otherwise, post DIP reconstructed breast, there is no point. There is no breast tissue left over there. We are not going to discuss about breast implant because it's a huge topic and we cannot cover here, but only one thing that I want to mention to the residents is whenever we are doing a mammogram in the patients who have implants, we can't just do our routine 4 views. We have to do additional views which are called as implant displaced view, where you kind of push the implants with your, the technologist push the implant and you take an additional view just to get the maximum coverage of the breast parenchyma. So now let's go on to the most important part, why we do the post-operative surveillance is because we want to detect the recurrent disease. So now recurrent disease, imaging appearance of recurrent disease is not any different from whether it is in the post-operative breast or it is de novo or it has come as a first time. It's just that we need to differentiate its appearance from a post-operative fat necrosis versus a recurrent disease. So yeah. So now here we have a case. This is 2021 CC view. And 2021 MLO view. This is a site of the surgery. This patient underwent, just 1 minute last, I'll finish off. This patient underwent right breast conservative surgery, and there is, we see this in the 2021, there is nothing at the scar site. But in 2023 mammogram, there is something which has come new, which was not there. It is not seroma, which will not come in, it was not there in 2021, it will not come in 2023. Those things will subside, but something which has come up new, we need to evaluate that. We did an ultrasound in this case, and this was subsequently biopsied, and it turned out to be invasive ductal carcinoma. Another similar case, this patient had another opposite side malignancy, and we had this 2019 mammograms, and in 2021 mammogram, there was some subtle AD which was developing. we were not sure, we couldn't find obvious ultrasound correlate because it was very hyperechoic. Although it did have an, elastography was very hard, but we couldn't find a correlate to point or a hypoechoic correlate. So we went ahead and did a CEM and we found that enhancing lesion. So if you, and then this was biopsied and it turned out to be invasive ductal carcinoma. Another similar example, this is again operated breast on the other side and subsequently developed the nipple retraction on the left side, which was evaluated further with the MR and which showed the enhancement of the, along the ducts. This was, this patient underwent surgery and it was turned out to be invasive carcinoma. So in conclusion, post-operative evaluation of breasts requires a comprehensive understanding and knowledge of various surgical procedures, the most important. The post-operative imaging appearance of a normal fat necrosis that we talk about, and then lastly, how the recurrent disease will appear. With that, I thank you.
One is, surgeons are also responsible for this fat necrosis. We have started doing a lot of oncoplastic surgery, a lot of fat movement that happens in the breast, and with the post-op radiation that we're giving, the chances of having a fat necrosis is much higher. But what's more important is to have an index of suspicion for fat necrosis being more than just a recurrence. Everything that you feel in the breast after surgery is not a recurrence. So one has to learn to pick this up clinically. So I think the breast surgeon who's examining or any clinician who's doing a follow-up of this patient should also know that there is something called as fat necrosis, which is probably more common than having a recurrence. Especially so when they've had a negative, it's not just seeing the patient, it's also knowing the histopath. If there is no high risk in the biology, if the margins were negative, if you had a good surgery done and you've had radiation given on time, treatment completed on time, it's not necessary that she will come, anything that comes in the breast is going to be a recurrence. Many a times it's just skin edema and there's a panic that's created and there's also been discussion on imaging, picking up skin thickening, and that definitely is an indication of recurrence. I don't believe in that because it's usually post-RT edema that's there, or a post-surgery edema. The second thing is the breast implant that was discussed. I thought I must bring it to notice here, because in oncology, when we put an implant, it's only skin remaining. It's skin, LD, and an implant. There is no breast tissue. There is no imaging to be done for that breast other than MR. We do not do a mammogram for a post-mastectomy subcutaneous, post-CA subcutaneous mastectomy implant because there is no breast tissue. So if we do that, we'll end up rupturing the implant and having more problems than solutions. So that displacing actually is only for when there is an augmentation done. That means there is a breast tissue, anteriorly there is a skin, and the implant has been done to augment the breast, because in such people, when you want to monitor the breast or you want to do a screening, you can displace that implant and go and take the breast in for a mammogram. But the compression that you put is going to rupture that implant, and I'm going to have major problems if that implant ruptures. So the essential thing is that this is done only for benign conditions, not for oncology. So I thought I'll just point that out. Yeah, thank you very much. So that was otherwise a very comprehensive thing, and it's good that you brought out the thing about fat necrosis and seromas, which are I think the bigger problem than recurrences. Recurrences, we have enough of imaging findings to find the recurrences, but to differentiate from a normal routine problem of fat necrosis and seroma is, I think, very, very important. Yeah, thank you, excellent. Yeah, thank you. This is going on and off. We have the last talk by Sneha. Is a good friend.
Yes.
She's a professor in the nuclear medicine department here in Tata Memorial Center, practicing in the field since last 20 years, interested in pediatric and women oncology imaging. I'm more interested in the women oncology imaging, and presently researching in theranostics. Interesting. Associated with the teaching program in the university. I think all of us here who have been here have always been teaching, and Sneha is a very excellent teacher for that matter.
Thank you.
She will be talking to us about place of nuclear medicine in breast cancer imaging and staging, choices of radiotracers and its appropriateness, and very appropriate talk to end the imaging sessions. Yes.
Good evening, everybody. I'm the last man standing. I know I'm preventing you all from going home. I'll try and be crisp. And so far, all of us have been listening to only localized imaging in terms of breast, as in mammo, ultrasound, MR and all. We're moving a little gears to look at imaging as a whole body, because we are looking at staging the disease. So I would say that we are complementing all the local imaging, what the radiologists offer in terms of breast management of breast cancer. I have no disclosures. Just a minute. So I will be discussing what do you mean by nuclear medicine. I know most of you are aware of it, but very often I get questions asked, what is the difference between gamma camera and PET imaging? So when we talk, I'll just let you know what it is and how nuclear medicine plays a role. Like I mentioned, it doesn't look at local imaging, it only looks at distant meds and the different radiopharmaceuticals we use. Unlike radiology, where you have one contrast which looks at enhancement pattern, which looks at angiogenesis, the tracers in nuclear medicine are a little different. We'll come to that in the next slide. So knowledge of pathology and pathophysiology is very important. I know it's important for everybody, but as a nuclear medicine physician, it is important because the radio tracer which I use is what, knowing the history, knowing the pathophysiology is what I would decide and what I will use. And that's why when I say I use a radio tracer, it's a contrast in terms of nuclear medicine, and it has two components. It's a compound. It has a carrier, means something which takes it. So when I teach the nurses, I tell them it's a torch to identify where the person is. So it's a carrier which takes my radioisotope to the site which I want to study. So if I'm looking at cancer, I want to know something which goes to cancer. And that's why I use glucose. All of us now know what is FDG PET CT, right? So the FDG is glucose. The glucose is the carrier which takes my F18 isotope to that. So it is a carrier with a radioisotope. Now you see three different colors for the isotopes that I've used: technetium, iodine, F18, gallium. So this is because the tracers used could be gamma emitting, or it could be beta emitting, or it could be positron emitting. So when I use tracers which are gamma emitting, I use a gamma camera. And when I use positron emitting tracers, I use a PET CT machine. So let me tell you, when I say PET CT, it's not the CT component. It can have three different types of CT components to it. The CT here, when on a basic term, is the hardware, because I use that for attenuation correction. But because the machine has a CT component, I can use that CT as a dedicated CT machine. So when you tell me, I only want a PET, please don't do the CT. No, it will be a PET CT, but the CT might be of a inferior low MA if I only want to use it for attenuation correction. But if I'm already doing a PET scan and I want a CT information, then I'll do a dedicated CECT associated with the PET and make it as a PET CECT. I hope I've understood, because so many times I get a call saying, I don't want a PET CT, I only want a PET scan. No, the PET CT is the machine. The machine which uses a CT component for a PET attenuation. So this I complete. So what happens in the DMG is the patient comes to you and you define clinically whether the patient is operable or an early breast. These are names which are synonymous, though there is a very little difference in them, and it's locally advanced. The clinician decides whether it's operable or it's locally advanced. And the main aim is to identify whether there is distant mets, because the idea is to decide whether the patient is a surgical candidate upfront or the patient is a surgical candidate only after having given neoadjuvant chemotherapy. So these are the two different workups which are done for patients. One where you have a chest X-ray, you have a USG abdomen and a bone scan done, which is a conventional method which is followed even in many institutes where PET CT might not be available, or a CECT abdomen, thorax and pelvis, that's TAP what we call it, or an FDG PET along with a CECT. Again, it's because we want to look out for M disease, not T. So let's look at the bone scan. There are three different tracers. Now, like I mentioned, technetium 99M is a radioisotope and MDP is a carrier. MDP is phosphate. Because we know bones have calcium phosphate, we use a phosphate as a carrier to take you to bones, to sites which are showing increased bone turnover, which is where malignancy is harbored. You could also have MEDP and sodium fluoride. I'll tell you the difference between F18 sodium fluoride bone scan and an MDP bone scan. Now let's look at what a bone scan does. It identifies areas of increased bone turnover, where the phosphate is being taken up more. But where there is no increased bone turnover, like in lesions which are lytic, you will not have an uptake. The turnover is poor. So that is the fallacy or a pitfall of a bone scan. Again, a bone scan can be non-specific. Like in these 3 pictures which I'm showing, all of them are showing uptake in the humerus. My God. Anyway, so you can see that one of the lesion is a diffuse infiltrative lesion, one is an enchondroma, and the other is just a degenerative changes. So bone scan is generally non-specific, and you might need to add on an additional imaging to identify what that uptake is. So it is a non-specific tracer, but it can be used as a screening out. So most of the times negative predictive value of a bone scan is good, but positive predictive value is not very good. So in a bone scan, like I said, the tracer is less. They are using a gamma camera. What if we use something which is having a better resolution? A PET scanner is supposed to have better resolution because of its uptake pattern. So if you see this picture now, it's the same patient. But if you see the uptakes, the focal uptakes are much better on the right panel as compared to the left. This is because I'm using a tracer and I'm using a modality which is a PET scanner. So it's better tissue clearance, better, and you also have an anatomic PET CT, I said. So I have the CT component also associated with it. So it gives me an overall better picture of the bones if I use a sodium fluoride. Now, like I said, what is sodium fluoride? 18F is a radio tracer and fluoride is the carrier. Sodium, calcium, fluoride, all of these are what your bone components are. So I'm using a carrier fluoride here attached to a fluorine 18 to get me this bone scan. What is better for a bone scan using sodium fluoride is better resolution and the CT component, as you can see here. So this lesion which is there, I don't have a marker here. So you can see that lower panel which has the actual pelvis here, you can see a very nice lytic lesion. On a bone scan this would not have been picked up, but because the uptake is 3 to 4 times more of a fluoride, you can clearly see a rim-like area and identify even a lytic lesion. Coming to FDG PET, which is the bread and butter now of most of the diagnostic nuclear medicine departments. Most of these departments do not have a gamma camera also. Like earlier nuclear medicine was called unclear medicine. With coming in of PET CT, it's become much clearer medicine because of CT attached. So like I say, the carrier is F18, the glucose, and the radioisotope is fluorine 18. What it uses is that every cancerous cell utilizes glucose 4 to 5 times more than a normal cell. And this is what we are extrapolating when we look at using FDG. Glucose analog is taken up by the cells as a normal glucose will be taken up, but it does not get reconverted because of absence of hexokinase and it gets trapped. It's too much of jargons. You must remember that FDG gets trapped in the cancer cells and does not leach out, whereas normal glucose leaches out. So that's how you see blobs increase tracer uptake. So this is a picture of an FDG scan. You can see all areas hot, the hot scans, wherever there is increased glucose utilization. Like I keep mentioning, there is no role for T staging with FDG PET because of its poor resolution for small lesions. I see all of you all are struggling even on a mammogram and an MR for that lesions. PET CT doesn't have that resolution at all. So do not use PET CT. Yes, if you have a very large lesion and there is a large breast, dense breast, and you think that there's something which is unequivocal, maybe you do an FDG, and if that lesion picks up increased FDG, maybe PET might just help you as a troubleshooter, but otherwise it's not used. We also have the advantage of it being a semi-quantitative, so you can use it for response assessment, which is not what we are looking here right now, so I'm not going to go into details with that. It is not useful for axillary nodal staging. Only extra axillary nodal staging, PET has a significant role to play, especially in identifying supraclavicular nodes and internal mammary nodes, which changes your treatment from upfront surgery to maybe adding on neoadjuvant or later changing your RT fields. And that is why PET CT has a role in end staging only in extra axillary nodes. And also, if you had a patient who was negative by other imaging modalities, and if your sentinel node and your PET CT shows you a lesion, then maybe you would avoid a sentinel node. So this is just a picture to show you how PET CT might show you that very small internal mammary node or that very small supraclavicular node which might not have been picked up. But if a CT scan would have been done, the supraclavicular node would have surely been picked up. Coming to M stage, which is the forte of PET CT, it is the maximum sensitivity and specificity in identifying M stage, especially in liver lesions where you have an equivocal thing identified on a contrast CT. And by incorporating a breath hold, it also overcomes the pitfall of missing out on lung nodules. Lung nodules, small, big, uptake, no uptake, the CT, the chest breath hold CT as a part of PET CT helps you identify whether it is disease or no. Uptake or no uptake is not the criteria. We are using the CT component to identify. So we're making it actually as a modality where you have the CT component of the CT thorax incorporated into PET CT and maybe a contrast CT and giving you a complete picture where it avoids sending the patient again to somebody else for a scan. These are just some pictures to tell you how useful for an M staging PET CT is. So when you looked at meta-analysis, you identified that PET CT had 92% of sensitivity and 99% of specificity for M staging, which was the best as compared to any other conventional modalities. But the most impact of PET CT is in identifying marrow disease. Bone scan cannot pick up marrow disease. CT scan cannot pick up marrow disease. PET scan can. And why is it? Because the uptake on an FDG is because the tumor picks it up. So if there is tumor seen in the marrow, FDG will pick it up, and that is why it is a very sensitive modality for marrow disease. We often sit in our MD meetings and you have a patient who's come after response where a CT scan is done and then you're seeing sclerotic lesions. But this patient, when a bone scan was done at staging, did not have any lesion. Now what to do? So maybe that patient actually, if had been evaluated with a PET CT to start with, had marrow disease to start with, and a healing lesion, sclerotic lesion is the one which is now being seen on a CT after NACT. And that is the meta-analysis which shows you that the PET scan has a 94% sensitivity and 99% specificity for marrow disease as compared to bone scan and any other modality. A new concept of treating breast cancer is oligomets, polymets versus non-metastatic disease. So patients who are already identified as oligomets, that is less between 1 to 4 metastatic sites which can be treated, are sent for a PET scan to identify or convert patients from oligomets to polymets, because again the treatment will change. So this is a patient who was an LABC who was planned for NACT followed by surgery. By doing a PET scan, you identified a marrow lesion and converted the patient from a non-metastatic to an oligomet. Similarly, this patient was a case of oligomet because of presence of mediastinal nodes, but identifying marrow disease, you converted the patient from an oligomets to a polymetastatic disease. This is an era of tailored therapy, and very often we are asked, because you're looking at the pathophysiology, you're looking at tracers, you have many specific already targeted therapies available, whether nuclear medicine will be able to help you in identifying those patients who are actually meant for targeted therapies. Yes, you can tag. I mentioned carrier, remember in the starting. So if you have a target on the tumor, and that target can be identified using your targeted drugs and tagged with radioisotope, you can identify whether that patient actually has those receptors or no. And that is where if you have estrogen receptors which can be tagged, you can have HER2 receptors which can be tagged, or the tumor microenvironment with the radioisotope I mentioned, either using antigens or antibodies and tagged with technetium, gallium or zirconium likewise. So these are called mapping scans. Just to give you an example, you have a patient who is metastatic, elderly, whom you don't want to offer anything, but you want to give endocrine therapy. To know whether this patient will really respond or not, you can do a mapping scan. Like this is a patient who's an ER/PR positive patient, and you can see that though the patient has been told to be ER positive, the uptake is not as significant as the FDG uptake. Means the tumor has a heterogeneity. It has ER expression, but it is not as dense or not as intense as it, I just take 2 more minutes, is not as intense as it would be on an FDG. So this patient might not be a really good responder even to an endocrine therapy. So this is used for mapping and for identifying tumor heterogeneity. Similarly, you have a patient with HER2. We all know that HER2 treatment is very expensive. Whether these patients who are going to be put on HER2 are going to really have a good intensity of HER2 expression. You can see these 4 panel images where you can have a patient matching whatever FDG is showing, HER2 receptor imaging is also showing. You could have some lesions showing HER2 positivity, some not showing, some showing no HER2 receptor expression at all. So this again helps you identify the histology and the heterogeneity of the tumor. And the last, where we're looking now at immunotherapy, looking at microenvironment, all cancer cells have fibroblast in its periphery, which makes it refractory. So using FAPI is a protein, inhibitor of a protein, something called FAP. FAP is a fibro-activated protein seen on the tumor cells. And if we target those proteins using an inhibitor, again I said the carrier is the inhibitor, the target is the FAP protein, and using a radioisotope gallium-68, I can map whether this patient is actually having a tumor or no. This is a very nice case which shows a patient with bilateral breast, one-sided having IDC, which you can see on an FDG very nicely, that focal uptake seen on the right breast. The other breast was a lobular cancer. On an FDG scan, you cannot see that up. But when we did a FAPI scan, you can clearly see both the lesions picked up. And this is why I just heard some people saying that lobular cancers, even on MRs, even on other modalities, are very difficult to identify because they don't follow the similar pattern. So maybe FAPI is a very good tracer to identify lobular cancer and its sites of metastasis. So coming to my last slide, I was asked to see what is appropriate in terms of nuclear medicine. Bone scan is appropriate. There is level 2 evidence for staging. FDG PET is also appropriate for the N extraxillary nodal and M staging. FES is FDA approved for staging tumors who are ER positive. HER2, there is level 3 evidence. We don't have enough data. FAPI is the budding on the block. Thank you.